Hi everyone. Hello. Hello leaders. Marvellous leaders. Isn't it fantastic to be in this room with all of you on a Friday afternoon too. So everyone can relax a little bit and enjoy the rest of the day. So before we start, I'd like you to turn to the person next to you and say, I'm so glad you came here today. I'm so glad. With feeling, people, with feeling. So it's always difficult to follow Dr. Feelgood. So let's see, I'll have a shot. The working title of my second book, Create a Great Quality System in 6 Months, was 50 Shades of Quality. How's that? I would say that for most of you, possibly, this was the title on today's program that was least likely to keep you awake with excited anticipation last night. Would I be right? Oh, well, we'll see what we can do about that. In fact, I met a fabulous woman just before who I haven't seen 30 years since we were both at uni, and the only thing she remembers about me is beer and motorbikes. So, quality can be very exciting. It doesn't have to be done. We're going to talk about all sorts of interesting things today. Well, I think they are anyway, but of course, you know, that's because I have a poor, sad, pathetic view of interest and excitement. But I want to talk about using who you are and what you know to create great experiences for your consumers. Because what we now know about safety and quality means that we need to use women's smarts to get where we need to go. Because doing things the same way that we've been doing them for decades now and expecting a different result ain't going to work. And I'm going to make some generalisations, there's no doubt. And I hope that you'll accept those in the spirit in which they're intended. Because you can talk about women's smarts and you can say, well, yes, I know lots of men like that. Absolutely, sure. But today I am going to make some generalisations. And I guess when I was thinking about this talk, where was it originally that I first realised that there might be a little bit of a difference between the way men thought about safety and quality and women thought about safety and quality? In fact, women, I think, have been quite schooled in thinking about it in a very male way. So we've got to change that. We've got to get back to our roots. And it was when I was an external experty sort of person on an aged care board, a large aged care facility, which shall be nameless, quite a while ago. And a discussion came up that they'd been doing some renovation on some of the aged care facilities. And unfortunately they found some asbestos. And so the CEO quite rightly said, to the risk manager, who was a guy, put that on the risk register and we'll discuss it next time. So he came next time, the risk manager, and he done exactly what the CEO had asked. He had put that risk on the risk register, and the risk was the risk of asbestos to our property portfolio. Yes, there were people living in these residential aged care facilities. Never occurred to him to think about the people aspect of that. And a little thing happened in my brain, and then nothing else happened with that for ages. It just kind of sat there. And I'll tell you when that got stirred up again in a minute. You've got to know the answers to these questions. If we want to provide something more than okay, or more than what we did yesterday, or more than patches of brilliance closely interspersed with patches of mediocrity, which I think probably is healthcare at the moment, you've got to know the answers to these questions. And I challenge you to have a think about them as we go through. And if you don't know the answer today, go away and think about it. Talk about it with your staff. Talk about it with your peers. Because if we don't have this at our fingertips, how can we ever really shoot for what we want to do, which is great consumer experience for every person, every time. And particularly that one, You know, I'm most interested to hear from high-performing organisations in other countries, and you know, some of the American health services now are saying we've completely flipped the proportion of time we spend in our high-level safety and quality meetings. Once upon a time it was all data, and maybe 5 minutes of what will we do about it. Now it's 5 minutes of data, and the rest of it is, okay, what's the strategy? What are we going to go out and do to help the people at point of care do this better? And I think if that is one thing we could do nothing else, that would make a big difference to the safety and quality of care at point of care. I love this quote. I've taken the liberty of inserting the quality bit, but I see a lot of this. I see a lot of activity in safety and quality that adds no value whatsoever, and a lot of activity that no one really knows what the value is. And no one's got time for that. And I think we have to start rethinking. Just doing more or trying harder is not going to get us where we need to go. For me, we're definitely at a crossroads. Once upon a time, the quality of care received by anyone entering a health service was entirely dependent on what? On what? Staff. Yeah. The person who looked after them, yeah? Who was on that shift? Who was on that floor? And that is fine when it works. Trouble is, it doesn't always work as well as we would like it to. People who provide care are human beings, yeah. They're working in an incredibly busy and complex environment, and with the best will in the world. Completely person-dependent quality of care is always going to be variable, always. And we kind of knew this, but we had to come face to face with it when we started to count. Quality Australian Healthcare Study, who remembers that? Oh, you just don't want to admit you're old, like me. Yeah. Do you remember what the result was? How many people we were harming? 16.6, yeah? Remember that figure and amaze your friends at your next dinner party. Yeah, you'll never be asked to another one, it's okay. 16.6%. That was tabled in federal parliament, and a lot of people got a big fright. Because we knew things went wrong. My great-grandfather died in St Vincent's, long before me, I'm not that old. Went in for an appendectomy and didn't come out. The nuns blamed the fish they had for dinner. Must have been food poisoning. Well, I doubt it was the fish, really. You know, what are the ways that they might have killed off my great-grandfather? Infection. What else? Medication. Sorry. No hand washing. Yes. Oh, speaking of hand washing, has anyone seen the innovation? I hope it was a woman's idea. I really do. With door handles, with gel dispensers built into the door handles. Wow! And when they've been trialled, the hand cleansing rate's gone. Isn't that fantastic? I love that. Yeah. Infection. What else? Get yourselves going, people. Sorry. Oh, something's anesthetic. Yep. Took the wrong thing out, bled to death, fell over and knocked his head. Who knows? The problem is, we'll never know. They weren't killing, and that was life. Yeah. So that's completely unacceptable now, and that's a good thing. But it's a big transition. From I'm a healthcare professional. I'm well trained. I'm totally dedicated to my patient. That's what I do. And I do my best and I give my best. It's hard to come to terms with the fact that even with all of that, you're still going to make mistakes, you're only human, you're going to have bad days. We're going to give you a bad system to work in that's going to trip you up. So we're in a difficult time. We are, up to me, definitely at a crossroads in all of this. Then we had the public inquiries into poor care. What was the first one? Well, come on, people, where's your safety and quality history? Or am I the only person who finds this interesting? I accept it. Bristol, thank you very much. You go to the top of the class. Yes, the Bristol Royal Infirmary in the UK, poor little babies having cardiac surgery with very, very poor outcomes over a long period. And when they unpacked Bristol, or tried to, they couldn't find, for the life of them, any chain of accountability. There was no one ultimately responsible for what happened to those little babies. And everyone went, oh, Maybe we need some governance around clinical care. Maybe we need some systems of accountability. Maybe we need some systems to support staff to do this well and consistently well. And so, around about 2000 in Australia, we started talking about clinical governance. I think Victoria was the first state to massage it into its Health Services Act, because we had a change of government and it was an opportunity to do so. And next thing you know, we've got a whole lot of things we have to do around clinical governance. And I think due to that knowledge and getting the fright, and it all being terribly public, of course, we went to all systems. We swung the pendulum, and before we knew it, we were taking things from airlines, and we were taking things from factories, and it was all lean, process redesign, crew resource management, human factors. Who remembers that? Okay. And I remember learning so much that my head was going to explode around about that time. And it was great stuff, really interesting, really useful, but I think not always well adapted in healthcare. Which meant that we learned a lot of great things, but when we put them in place, we kind of bung them on top of what we were already doing, rather than rethinking the way we approached providing safe quality care. And to me, what's happened is as a result of that, is a whole lot of transactional stuff. So we do lots of things in the name of quality. People show me their quality plan and it's like pages of activities. Sometimes it's just a quality manager to-do list. Sometimes it's quite strategic. But I very rarely see a quality plan that is all about achieving goals at point of care for every person every time. I see a lot of good stuff, not necessarily very focused. They're very transactional. So you end up with lots of good maintenance. I mean, this is important. Don't go home and say, Cathy said we don't need to do policy and standards anymore, because that'll be the end of a beautiful career. Yeah? Please don't. Important foundation. But I see a lot of quality systems that stop right there. Any quality managers in the room? Anyone willing to admit they're a quality manager? No? Anyone know a quality manager in their organisation? Yeah. These people have terrible lives. Really. People still run away from them in corridors, just like they did with me. I had 3 cleaners hide in a cupboard to get away from me once. Very small cupboard, very big cleaners. I opened the door and I said, we have to have a conversation about accreditation. You can come out or I'm coming in, I don't mind. There's something not quite right about that. Yeah? You'd like people to be running towards you, wouldn't you, rather than away from you, but we haven't quite cracked that yet. Today, we're going to. So I see some good improvement stuff, but often it's incremental. It's not for want of trying, or investment, or policy, or new standards, or training, or departmental initiatives, is it? There's tons of that. There's no problem with the amount of stuff we've got to do around quality. But what has happened as a result? Well, if we look at some data, we've kind of plateaued. So many of you will know the Care Track study. 57% of patients receive care based on best available evidence, which might seem okay, unless you're on holidays and you get admitted to Karratha Hospital and you happen to fall into the 43%. Yeah. Not so good. We've got some, we don't have much data about ambulatory care. I see a couple of ambulatory care people in the audience. We need a lot more good data around this, but 5% misdiagnosis rate around ambulatory care sends those people off down the wrong path from which they may never recover, and they might never come back. This is an interesting one, and this study is not unusual. From the States, 9,000 patient records over 8 hospitals. 25% of patients have at least one hospital-acquired adverse event. 25%! That's a lot. Voluntary reporting captured less than what? 5%. It's all right, I don't ask trick questions. Less than 5%. So anyone here who is completely dependent on their incident reporting to tell them their level of risk and how safe their patients are. It's tip of the iceberg, people, tip of the iceberg. Here's AHW 2011-12, overnight separations we're looking at there with adverse event per 100 separations. As you can see, the publics, the privates, and the total. Now, we seem to have plateaued around about 10%. I reckon we're probably at any given time somewhere between 10 and 25, really, in reality. But we've plateaued. It's been like this for about 10 years, and we can't get off. Now, one of the reasons we have medical safety quality standards that are A, mandatory, and B, compliance-based, which many people think is a retrograde step. But one of the reasons for all of that is to try and knock us off our 10% adverse event rate. Because with the best will in the world and all the stuff that's happened in the last 10 years, we are well and truly stuck. We also know that we still have poor care, mid-staff being the most famous, certainly in the last couple of years. I do like woman falls in hospital told to call ambulance. Hospitals resort to hiring doctors. Wow. Thousands dying of thirst. Some of you will know, many of you will know, that the patients in the mid-staff hospitals resorted to drinking from flower vases because no one would bring them a drink. No one would bring them a medication to give them pain relief. No one would take them to the bathroom. No one would answer their bell. And when Robert Francis QC described it as appalling care, he wasn't joking. So this can still happen, despite everything. And the NHS of any health system has been at this with a will, this safety quality thing, for a long time. So you've got to think, don't you? Let's not keep doing the same thing and hoping for a different result. So then we tried patient-centred care and consumer focus and all of those words which drive me a little bit nuts, really. But with the same mechanistic scientific mindset and systems, yeah? So there's nothing wrong with being consumer focused or patient-centred, nothing wrong at all. But it's a bit like what happened after the Colin Strain healthcare study. We've taken this stuff and we've got to bung it on top of what we've already got, which is a very mechanistic approach. So we end up with this. We've got to focus more on the needs of our customers, says the CEO. Poor old Gilbert. I've hired famous business consultant Tom Peters to follow you around and make passionate criticism. Poor old Tom Peters. Is this quality? Are you truly focused on the customer? Yeah, great. Use this better. Yeah. I see a lot of that. Lots of talk. Not a whole lot of reorganisation with the patient at the centre. But lots of talk, lots of projects, some of which are hitting the mark. Absolutely. But not all. We're far from really changing our mindset, I think, around this. So that's what I want to talk about now. So what's happening? Well, a few things. Firstly, I know we know this, but health services are not factories. We certainly often behave as if they were. Just one thing follows another in a logical order, and everything kind of goes in one end and comes out the other. And hopefully when it comes out the other end, it's better than when it came in the first end. Focusing on the negative, which we do heroically, consistently, to the point where I think, how many more incident reports do we have to collect before we are satisfied that we know what the issues are? But it's only half the story. Somewhere we missed the message from other industries about customer service and value creation. So when we pinched all that stuff from other high-risk industries, great. But they also have a great, big commitment to customer service and value creation that we kind of decided maybe we'll pay attention to that later. We'll just get all this risk management stuff first. We'll do that because, that's tough. There's customer stuff. It's a bit fluffy. Worry about that later. But just taking the risk management components from other high-risk industries and forgetting this really important stuff, I think, was a big mistake. So now we're playing catch up. Healthcare is a complex, adaptive system. Who feels a little shiver of excitement up their spine when I say that? You should see the looks on your face. It's like, who let this woman in here? Billy, get her off! Well, the first time someone explained this to me, I nearly levitated. It's true, I was very excited. because I knew there was something missing. I knew all this counting and analysis and looking at reports, whilst very important, was not actually addressing what really went on at the end. It was very removed. And so, complex adaptive system is a road system. It's a small town. It has a personality. It's got lots and lots of interdependent things that all have to come together in a beautiful way to make your trip to work safe and efficient. Yeah? It's hard to get right. It relies on a whole mix of systems and rules and intelligent people making good decisions and not being tired or stressed or having just had a fight with their partner. Wouldn't we love to have zero road toll tomorrow? Yeah? Why don't we? Lots of reasons, yeah? Same with health. There are so many factors we have to get right. But that shouldn't stop us striving for it. So, yes, complex adaptive system, no factory. You can only standardise so much in a complex adaptive system, which is kind of interesting when we talk about reducing variability. Yeah? The trick is to standardise what you can, standardise certainly the high risk things as much as you can, but you also need people to think. When I sat by my aunt's bed a couple of years ago, when she was dying of cancer, and I was working away. In fact, one day I had my ACHS folder there because I was about to do an accreditation survey. And just as a quick aside, it was an evening nurse walked in and must have had something to do with accreditation because she took one look at my folder, turned on her heel, and went straight out of here. Next thing I had the evening supervisor saying, "Can I help you?" I thought I'd snuck into a little survey on the side. Amazing. But I saw people come in, allied health, nurses and docs, and really carefully read the notes, really carefully look at the machine, make their recording, and hardly anyone put a hand on it. Hardly anyone looked at it, And I know people are busy, and I know people are stressed. I totally get that. But in a complex system, systems will get you a long way, but they'll only get you so far. Because we're not factories. No. 20 to 50% of procedures in complex systems are not fully followed. And you know that. As you sit here today, about half your beautiful policies and procedures are being completely ignored. Sorry. I know how much work you put into them. Sometimes that's because we give people unrealistic policy and procedure that doesn't actually work in the, in the daily grind. We write them in an office and we might chat to a few people and then we say, hey, now implement this. But partly because in a complex adaptive system, when things start to slide, which they do often, towards an unsafe envelope edge, happens a lot because of the different factors that are, working with and against each other. If people don't think the policy or procedure is going to get them where they need to go, to make that situation safer or shorter or easier, they will just work around it. We know that. Yeah. It's in the nature of complex systems. A key driver of how things actually happen is staff beliefs, their judgment and their behaviours. You know that. So my levitation moment came with some amazing people who really get this stuff. And getting this stuff, to me, is 3/4 of the way to being able to really do something different about this. Amazing people like Rhona Flynn, who knows everything there is to know about safety on a deep sea oil rig, and is translating that to health. I remember the first time I heard her speak, I went, oh, poor woman. I was sitting there with my dilated pupils. This is incredible. She left very quickly when she finished. I don't think I understand why. Jeffrey Braithwaite, who's heard Jeffrey speak? Yeah. When he really introduced me to complex adaptive systems, and I thought, oh, that's how a health service really works. That's good. Let's talk about health services, how they really work, warts and all. Like the road system, good times, bad times. Yeah? The lovely Kathleen Sutcliffe. If you haven't read Managing the Unexpected, read it. It's fantastic. Sydney Decker, who said you can't just count your wage safety, to a room full of clinical risk managers who then all looked very purse-lipped and uncomfortable because they didn't like him saying that one little bit. Because a lot of clinical risk managers I know spend a lot of time counting incident reports, and that's kind of what they do. So if you take that away, what are you going to do? These people with deep understanding of how our health services work. Absolutely fantastic. In fact, I was so taken by what Sydney Decker was saying. He was about 2 slides to the end of his talk, and he had to finish because he had to race off somewhere. So he said, "Oh, look, I'm sorry, I can't finish my last 2 slides." I went up to him with my eyes bulging and said, "I must see your last 2 slides." And I'm sure he muttered to the person who was walking out with him, "Call security." But when someone explains it to you and says, "Look, health services are like a village. You've got to get to know them. You've got to get to know how to get the best out of them. Not just bung a whole lot of systems and processes on top and count a lot of stuff and hope somehow that that'll make things different at point of care." And of course, one of my great inspirations is Lisa Simpson, who constantly reminds me to keep learning and to keep questioning. So you're thinking, well, Cathy, I guess eventually, this is all very good, you will get to your point. Well, my point, and I do have one, yeah? Safe, quality consumer care in the real world. You have to understand and appreciate consumers as human beings who deserve a great experience. Right? It's not about the property portfolio, it's about the people in the buildings, yeah? Staff as human beings who need and want to do a great job and need direction, knowledge, resources and support to do it. I've read 100 books on staff empowerment, enablement and engagement, so you don't have to. Now that's worth the price for admission, really, just on its own. Because some of them are pretty dull. Always comes down to the same stuff. Direction, where are we going and what's my role in it? Knowledge, do I have the understanding and skills to be able to go on that journey? Resources, expecting me to do this on nothing, and support. Encouragement, feedback, and it's got to be awful. And as you know, in health, sometimes we come together and do that well. Mostly I see one or two. And people say, "Oh, but no one wants to engage in quality, Cathy." And I think, well, maybe I wouldn't either if I were me. I'm getting a D, but I'm not getting anything else, you know? I probably don't get a few very good Ds either. You've got to define a great consumer experience and what staff bring to it as the concrete foundation for greatness, not as the soft and fuzzy stuff that the quality manager does on Tuesdays. The CEOs I know that do this stuff well use their quality system to drive their business. They don't have a business and then say, "Oh, but we've got to do quality as well." A deep understanding and appreciation of how things really work on the floor where care is planned and delivered every day. Yeah. So I read something quite recently. Some of you may have seen it. That there's a tipping point of around 92.5% occupancy, after which mortality goes. Isn't that interesting? Those of you from hospitals, think about your occupancy rates. Be very afraid. Yeah. So what happens on the floor when it gets to 93%? Because I bet you things change. And you need to deal with that reality rather than how things are at 80%. Yeah? The knowledge, skills and problem solving staff bring to their work are critical to creating great care and complex adaptive systems. We need them to be intuitive and resilient. We want them to find and learn from the things that go well, because guess what? In a complex adaptive system, that is a great way to make change. Let's stop focusing quite as much on the things that go badly. I mean, yes, we need to keep learning and fixing, I totally get that. But in a complex adaptive system, finding the bright spots, learning how people make those things happen. I mean, don't you think it's incredible that, you know, more or less somewhere between 80 and 90% of the time things are going reasonably well in healthcare, considering it's amazing. So let's learn from the people who do it well in our organisations and spread that. And what guides behaviour in human beings? Logic only influences how people think. but emotion influences how they act. Yeah? So you can tell people at point of care till the cows come home that X, Y, and Z is important, and we must be very person focused. But if you don't appeal to here, that's going to be a struggle. Give them freedom, give them a framework of all of this, and let them use their good knowledge, their skills, their judgment to create something amazing. Women smarts, that's what we need. That's what all that stuff is about. It's about respecting intuition, which after all is only pattern recognition. That's all intuition is really. I don't mean all fantastic. But you know, if you visit another health service, don't you know in 10 minutes, you kind of get a feel, is this a good place or a bad place? Would I like to work here? How does it smell? Are people smiling and happy? What are they saying? How do they act towards each other? Yeah, you get that, don't you? Totally. As a surveyor, you know it in half an hour. So the rest of the survey is just a waste of time, really. Everyone awake out there? Hello? Yes, I'm only coming to survey you for half an hour. Yay! Yeah, that's more like it. I was expecting wild cheering and throwing of hats in the air. We know the pattern. We know the pattern for good. Let's tune back into that and create that pattern for good. Trust our intuition. We know when it's not good. We don't need a whole set of data, the same stuff over and over again to tell us. Yeah. So, finish off a few thoughts. Smart women see the big picture. This is often what I'm introduced to in people's health services as their quality system, which to me is really the governance system engine room that's got to be driving something. There's the poor old people out there trying to make it happen every day. And there's a terrible dance often between the quality manager and the managers and the staff about, well, you know, you've got to be engaged in this planning and you've got to be consumer focused and don't forget to go to that training, and while you're at it, you know, make sure you're doing that thing right in that policy. And then they say, oh, staff are not very engaged, Cathy. And I'm like, no. What staff want to do is that. They want to be purposeful. They want to create a great consumer experience that is clearly defined and that they're supported by that governance system engine room to do every day. This is what they come to work for. Let's work with them on that. Let's say, we will help you be empathic and skilled and informed and proactive and accountable to create this great experience. Let's say, we'll give you direction, knowledge, resources and support, because this is the most important thing. And then, then we have a real strategic quality system that's going to take us somewhere different to where we are now. Yeah, make sense? Yep. 5 steps for you. Because you knew I wasn't going to let you get away with, oh, well, that was nice, you said some things, I had a bit of a laugh. Got no idea what you're talking about, really. No. We need you. People, you are the leaders. If you don't go back and start thinking about this differently, in 10 years I'll be having the same conversation. I can assure you, I am not retiring until we get this right. That's a threat and a promise. Yeah? Decide to be a great leader. Decide today. I'm going to stop and listen to my intuition. I'm going to look at what's really happening at point of care, not how I'd like it to be happening. I'm going to work with people at point of care. I am going to support them to create a great consumer experience that we define together. Understand. You've got to work with your staff to do that. Don't just hand it down like stone tablets. Oh, I see that all the time. Standardise what you can, but also tap into the intuition and creativity of your staff. This is not an easy thing, but healthcare is not easy. You know, I often say to board members on health services, you know, you want easy? Go be on the board at BHP. Find it, pick it up, sell it. What's so hard about that? You want a challenge in your life? Stay on the board of health service. This is not an easy gig. It's not easy for you, it's not easy for your staff. But we make a difference to people's lives, yeah? And there's nothing greater than that. Develop the resilience of your staff to cope with the demands of the environment. They'll perform better and they'll love you for it. And increase the things that go well and reduce the things that go wrong. That's all I ask. Not much at all. What drives the quality and safety of care is not the soft stuff. Is there anything soft about those people? Are they absolutely terrifying? It's not the soft stuff. This is the stuff that makes a real difference at point of care. Not looking at a graph in a boardroom, people. That is important too. Don't tell people no more graphs, Cathy said. We've got to get the balance right. So that you have your maintenance, your improvement, but in the end, you actually are getting somewhere towards transformation. And that's what we should be aiming for. Get on my website and pillage it and pilfer it, because that's why it's there. There's a ton of stuff around this. Please do. I'm going to, if anyone would like, give you a book. I've got some books here that poor old Billy and Jane had to sell their soul to find, because they went missing today. Yes, thank you, very pointing. If anyone wants to come see me after, the only thing I ask is for your business card. So I can have your soul on my newsletter list. Learn about the stuff. When you start learning about it, you'll recognise it. You'll say, oh yes, this is how things really work. Oh, I feel so much more comfortable with this. Yeah, I can work with this. So there'll be less of this. Less of Alice getting the first recipient of the Motivational Stone Quality Award. Believe me, I've had a few of those in my life. And all you want to say is, if you just paid a little bit more attention to me and gave me a bit more support, I didn't need the $1,000 engraving. Yeah? But I did, yeah, great. Yeah? Oh, yes. Less of this and more of this. Systems awareness and design are important for health professionals, but they are not enough. They are enabling mechanisms only. Ultimately, the secret of quality is love. You have to love your patient and your profession. You don't have to like them, okay? But you have to love them. If you have love, you can then work backward from that to monitor and improve your system. Now, that was not some great healthcare quality person. That's not Berwick. That's not anyone you probably know. That's Avidus Donovidian, who was a health economist. And he got this stuff better than we did. That was the last interview before he died, and that was his last message. Someone said, what would you say overall about achieving great care for our consumers? And that's what he said. Absolutely brilliant. You have to admit. So I want you to turn to the person next to you and say, next week I will lead a new attitude to creating great care in my health service. Go. Next week I will lead. All right,